Now starting on respiratory physiology. Mentioned in the last video, pulmonary ventilation. So pulmonary ventilation is actually the process of breathing that we think of. So it's actually getting air into and out of the lungs. And so we say inhalation or exhalation. So you can think of it also as inspiration, so taking air into the lungs, and expiration, getting air out of the lungs. So this is actually getting air from in nose or mouth into the lungs so that gas exchange can occur. This is what we call maintaining alveolar ventilation. So pulmonary ventilation is going to maintain alveolar ventilation because we know the alveoli are where the gas exchange actually occurs. So this is where we need gas to get down into, meaning oxygen, and get rid of carbon dioxide. So that's ultimately where we want the air to go down into, because then we can have everything kind of exchange happen there. So we want to maintain airflow. So pulmonary ventilation is airflow into the alveoli, ultimately going the conducting zones down into the respiratory zone, which is the alveoli. Then remember, external respiration isn't happening outside the body. So there's a difference between pulmonary ventilation, where you're bringing the air in. Once you bring the air in through inhalation or inspiration, then external respiration can occur at the alveoli. So this is where the air from the alveoli or going into the alveoli occurs. So blood in the pulmonary capillaries, oxygen goes into the pulmonary capillaries, and carbon dioxide leaves the pulmonary capillaries. So you can think of this as external respiration. It's external because it's with external air. The air came from the outside into the lungs, or it's going from the inside out. So this is exchanged with external air, came from the outside of your body and went into the lungs. Or if it's going the opposite way, it's going out. So it's having to deal with some sort of external component, which is the air. Internal respiration occurs completely with everything inside the body. So this is exchange. So it goes external respiration, oxygen, talking about oxygen here. Oxygen goes into the capillaries, travels through the veins to the heart, and then go through into systemic circulation. What's the point of the bloodstream and systemic circulation is to get oxygen to the tissues. That's ultimately where we need oxygen to go to, those cells in the tissues, because then they're going to use it to make ATP and all their chemical reactions. So this is exchanged between the blood, the oxygen's inside the blood. We've already gone through external respiration. Oxygen's in the blood, and then it travels into the tissue cells. So it's absorption of oxygen by the blood. And then we have the opposite with carbon dioxide. Carbon dioxide, again, is the waste product that we produce. So tissue cells want to get rid of carbon dioxide. So it's going to go from those cells in the interstitial space into the capillaries and then travel back. So this is happening all on the inside because it's between the blood and the tissue cells. So this is looking at both. So we have external respiration. Again, pulmonary ventilation occurs, gets air into the lungs, and that's when external respiration can occur. So we maintain alveolar ventilation, meaning we maintain air in the alveoli, and we can make sure that we continue to get oxygen, and external respiration can occur where oxygen travels into the blood, carbon dioxide travels out of the blood, and then travels throughout the body to other capillary walls, and then internal respiration occurs where we're delivering the oxygen to the tissues and the tissue cells, and we're removing the carbon dioxide from the tissue cells into the capillaries, and then start the process of go over again. So, a little overview because this is going to come into play a lot with air movement. When we talk about air movement, it's based on pressure. So, still remember diffusion, where we went from high concentration to low concentration. Air is going to move in kind of high pressure area to low pressure. So it's similar in the movement where it's going high to low, but it's just based on pressures versus necessarily concentrations. So we talk in reference to atmospheric pressure. So that's everything on the outside of your body. So the pressure of air on your body is called atmospheric pressure. And you hear it when you talk about the weather. So, like low pressure systems and high pressure systems, it's changes in the atmospheric pressure. So, it's everything kind of outside your body. When we talk about respiratory pressure, we're describing it in relation to atmospheric pressure. So, if we say respiratory pressure is negative, that means it's lower than atmospheric. I should say lower than atmospheric. If we're saying it's positive, then it's higher than atmospheric. So we're going to see it in the next slide. And then if it's zero, it's equal to. So zero equals equal to. We're going to see this on the next slide or coming up, but just kind of starting out. So you imagine if we're going back from high pressure to low pressure. If outside your body is higher, so you have negative pressure inside your body, and it is lower than outside the body, then air is going to move from high pressure, which is outside, to low pressure, what's inside your lungs. If we have positive pressure and it's greater than atmospheric, then it's going to go from inside or the higher atmospheric or the higher pressure to outside because it's going to go high to low. If it's zero and it's equal, there's going to be no movement. So we're going to talk about this is kind of how we're breathing is changes in pressure. If it's negative, then air is going to move from high to low. So it's going to go from outside in. If it's positive, it's going to move from inside out because it's going to go from higher pressure to lower pressure. And if it's zero, it's going to not move at all. And we talk about two types of pressure inside the lungs or inside the chest cavity, the thorax. Intrapulmonary pressure. So let's break it down. Inside means intra, pulmonary means lungs. And we're talking specifically about the alveoli. Why? Because this is where the gas kind of matters, because that's ultimately where respiration, the external respiration, is occurring. So that's where we need the gas to go to, is in the alveoli. This pressure changes with breathing because this is where it's going in and out of. It's going to go into the alveoli and then into the bloodstream through external respiration. It's going to go out of the bloodstream into the alveoli and out of the lungs for external respiration if it's carbon dioxide. So when you're breathing, eventually it equalizes with the atmospheric, so you get zero, where there's no movement. Why? Because, well, you need to stop and go from breathing in to pause, breathe out. So kind of just think about what happens when you're breathing. Kind of just pay attention as you're breathing, what's actually occurring. And then we have intrapleural pressure. This is pressure in that pleural cavity. So remember, we have a parietal pleura, which is going to be on the actual thoracic wall. And then we have a visceral pleura, which is actually lining the outside of the lungs. And we have space in between that's called the pleural cavity. This changes with breathing as well, because we're going to look at the size of the thorax changes, but it's always going to be negative, meaning it's always going to be less than atmospheric. Why? Well, this is going to be negative, which is allowing your lungs to expand. If this was positive and putting more pressure on the lungs, they won't be able to expand as much. So they need to get larger and then smaller as air's coming in and out. So it's always negative to allow expansion of the lungs. That's why if you have kind of a chest wound, if all of a sudden someone gets stabbed with a knife, then they worry about collapsing of the lungs because you're changing that intrapleural pressure. So looking at gas volume and pressure, we're talking more kind of volume and pressure kind of go hand in hand with gas molecules. So when gas molecules are just traveling around, they bounce off of things and move around kind of not in relation to each other. So you see a liquid, we can flow together. Gas doesn't really do that. There's just molecules that are just kind of going every which way and traveling kind of away from each other or towards each other. So it can just be all kind of chaotic. So when you have air in a container, then the air bouncing off the container wall is what's causing the pressure. So it's pushing against the container wall, causing pressure because it's all these molecules bouncing off of it. If you have more molecules moving and hitting against the container, then it's more pressure because there's more collisions, more molecules are pushing. There's more pushing, there's more pressure. So think of it as someone trying to hold the door closed on you and you're trying to open it. If you have one person, well, maybe there's not too much pressure and you can overcome it. If you have 20 to 1 trying to hold the door closed and you're trying to open it, well, there's a lot more pressure. So think of it as more kind of people, more collisions, more pressure. If you take, let's see, 1, 2, 3, 4, 5 molecules that I have in here in this container, in this size container, and all of a sudden you put it to this size of a container. Well, there's going to be a lot more collisions because there's nowhere for these molecules to move elsewhere. They have to collide with the wall because there's nowhere else to go. So again, kind of with my people analogy, think of if you're in this large auditorium and there's 20 people in it. Well, you can walk around blindfolded and you'll hit the wall, but you may not hit it as often as all of a sudden you go into this teeny tiny closet and you still have 20 people in there and you're going to be bouncing off each other, you're going to be bouncing off the wall, you're going to be hitting a lot more things and you're going to hit the wall a lot more often because there's just nowhere else to go versus if you're in a large auditorium. Still hit the wall, but not as often. More times you hit the wall, the more pressure there is. So when the molecules are in a smaller container, we're going to see more hitting the wall, which is more pressure. So this is coming into what we call Boyle's law, one of the laws that'll help you kind of understand respiration. So this is looking at what we just discussed of the pressure between the relationship between pressure and volume of a gas. So this is going to say pressure inversely related with volume. So when you increase the volume, so you increase the container. You can think of a volume of a gas. A gas is going to fill the container that it's in. So when you increase the container, you're decreasing pressure. So again, if you're going from this teeny tiny little container and you have the 5 molecules versus going to this larger container and you have 5 molecules. Well, again, they're going to hit the walls less often here, so exert less pressure on the container versus over here. Decrease volume, you're going from the larger container down. So you have a smaller container. Smaller container, you go from having tons of space and you can spread out to all of a sudden a teeny tiny room. Well, you're going to hit the wall more often. So there's more collisions. So there's an increased pressure. So when volume goes up, then pressure goes down. If volume goes down, pressure goes up. They're always going in the opposite direction. So volume is inversely related to pressure. And that's Boyle's law. Volume goes down, pressure goes up. Volume goes up, pressure goes down. Always opposite directions. So this is just looking at it a little different. So you have gas molecules in a sealed container. So again, you can see they're moving all around in independent directions and they're bouncing off the wall a little bit. A couple of molecules are going, and all of a sudden you're able to push the seal down. So you make volume decrease. So you make volume decrease. Well, look at all these molecules. There's a lot more that are hitting the wall or going towards the wall because there's just less room to move around. So again, think of it as you have 20 people in a large auditorium. You're not going to bounce off each other. You're not going to bounce off the walls as much versus if you all of a sudden are in this tiny, teeny room, you're going to be bouncing off each other and bouncing off the walls a lot more. You're going to be pushed to the side. So same thing, if volume decreases, which is right here, volume's going down, then pressure's increasing. If you go this way, where all of a sudden you're free, you have tons of room to move around, then volume's increasing, pressure's decreasing. So remember Boyle's law. So why are we talking about this? So it comes into play with pulmonary ventilation. It's going to be the first part that we see. So what you do to breathe in and breathe out is actually changing the volume of your thoracic cavity. So think again when you're breathing. What's happening? So what happens is your diaphragm, the major muscle of respiration, it's the big kahuna, and your rib cage, so we're going to talk about intercostal muscles, are going to change the volume of your thoracic cavity. So you're going to either allow expansion of your lungs or compression because you're going to change the volume that the lungs can have to expand in. So you change the volume, you change the pressure. So what happens with the diaphragm? Usually it's kind of domed and then all of a sudden it flattens out. And then you have a superior kind of upward movement of the chest cavity. So you go from chest cavity where it has dome and all of this to all of a sudden you expand. So what did we talk about if you're increasing the volume? Then you're decreasing the pressure. So take a deep breath in. Your chest expands and you're actually decreasing the pressure. Then when you're breathing out, what happens? Opposite. All of a sudden, your rib cage goes back, it retracts in, diaphragm goes up. So you're decreasing the volume. So you're increasing the pressure when we talk about Boyle's law. So mention this, diaphragm contracts and it moves inferiorly and flattens. So better kind of looks at it. So the diaphragm, major respiratory muscle. It flattens out. So this is flattened, this is more domed when it's relaxed. Then you have your external intercostals are going to contract, and that's what's lifting your thorax superiorly. So you can see the external intercostals are kind of lifting, and they're all in between the ribs, so they're all kind of contracting and lifting up. So the diaphragm contracts and flattens out, which is increasing your thoracic volume. So think about what's happening with pressure. If you're increasing volume, you're decreasing pressure. External intercostals are contracting, lifting your ribs out, up and out. What are you doing? Increasing thoracic volume, decreasing pressure. So your intrapulmonic pressure, the pressure that's in alveoli, is decreased. And so it's negative. And it's even more negative. So what you're doing, you're decreasing the pressure. So air is going to flow from higher pressure, which is going to be atmospheric, to lower pressure, which is going to be inside the lungs because you've decreased your pressure. So air is going to go from high to low. So you've increased the volume of your thoracic cavity, meaning you've decreased the pressure. Air is going to go into your lungs. If you want to do forced inspiration, and this is deep, and it's not necessarily just kind of like it's difficult, it's just saying it's extra. So normally when you're resting, you're just kind of breathing in and out, and it's normal. But if you want to take a deep breath where you really want to breathe in, if you're exercising a lot, you need to take deeper breaths, or even people that have obstructive pulmonary disease, then you actually have to use accessory muscles. So this is going to be muscles other than the diaphragm and the external intercostals, because those are going to be considered primary inspiratory muscles, are going to be the external intercostals and the diaphragm. If you need to take a deep breath, you're going to add muscles kind of the chest and neck. So your scalenes in your neck, your sternocleidomastoid, and your pectoralis major, so chest and neck muscles. That is, so if you kind of remember, scalenes are coming down and they're actually attaching to the thorax. Sternocleidomastoid is attaching to the clavicle and the sternum. And then your pectoralis major is going to be attached to the rib cage as well. So you're just going to increase the thoracic cage even farther. So again, normal inspiration, you increase the thoracic volume, but if you increase it even more, where you're increasing volume more, well, then you're going to decrease pressure more. So that's going to allow more air to move into your lungs until we get kind of equalized pressure, and then it stops. So there's only a certain amount of air that you can breathe in and how kind of big you can make your thoracic cavity. But if you really need to take a deep breath, you can kind of increase the volume as much as you can so you can decrease the pressure. More air is going to move into the lungs. So we talked about inspiration. Now we're going to talk about expiration. And this is what we considered a passive process. Why do we consider it passive process? Nothing's contracting, at least in normal expiration. So just normal resting, breathing, do kind of normal breathe in and breathe out. So what's happening is the inspiratory muscles are relaxing. So nothing's contracting, everything's relaxing. So again, this is normal. So the inspiratory muscles are going to be your external intercostals are going to relax. And your diaphragm, the big kahuna, is going to relax. So what's happening when these are relaxing? Remember, the diaphragm flattened out and went inferiorly. So it's going to relax and dome and go superiorly. Your external intercostals were lifting your rib cage kind of up and out. So they're going to relax. and the thoracic volume is going to decrease. So you can see kind of the difference in size of the thorax and lung area here versus here. So again, we're going to decrease volume. So it comes into Boyle's law. Pressure is increasing because it goes opposite direction. Volume goes down, pressure goes up. The collisions in this area are going to happen more often than the collisions in this area. So now we're going to get a positive pressure. So this area is going to be higher than the atmospheric pressure out here. So pressure changes where high pressure here and lower pressure here. So air is going to move from high pressure to low pressure. So it's going to move out. And this is just, again, from the inspiratory muscles relaxing. So there's no kind of active process because nothing's contracting. So air moves from high pressure to low pressure. It moves out. Lungs can recoil too, so there is elasticity, and we'll see in lab that there's elastic fibers around the lungs that help with kind of the snap. So when lung volume increases, so you can think of it as a rubber band, you're kind of stretching it out and then you release it. What happens? Well, it snaps back. So that's going to help with movement and pressure as well, of just the recoil of the lungs, them snapping back to their normal size. That's going to help force air out as well. Still a passive process. You're just kind of letting go of the rubber band and it goes back to size. And remember, this is another important part of surfactant made by those pneumocyte type 2 cells that are going to help reduce that surface tension, keep the alveoli open. So when they're snapping back, they don't actually collapse. So you can expand them and retract them a little bit so that they don't collapse, but air is flowing out. Just like when we had a forced inspiration, we do have forced expiration, which is going to be an active process. So this is when we actually have muscles getting involved and contracting. So abdominal muscles, when you kind of push air out, so you're actually sighing, think of it that way, like breathing air out, you actually contract your abdominal muscles. And you're going to push the diaphragm upward. So if you're pushing the diaphragm, again, normally when it's relaxed is going to be kind of domed like that. If all of a sudden you're pushing it even farther up, well, what are you doing? You're decreasing the volume even further. So decrease volume. What does that do to pressure? Increases pressure. So you make an even larger difference. So more air is going to move out because remember, kind of the bigger the difference, the more molecules are going to move. You also have your internal intercostals, still between the rib cage, but different kind of fiber arrangements underneath the or deep to your external intercostals. And so they depress the ribs. So again, what are you going to do? If you're depressing the ribs, they're going kind of down, further in, shrunk in. Then you're going to decrease your volume further. And you're going to increase your pressure further. So again, more air is going to move out. So greater pressure difference between the atmospheric and intrapulmonary, the more air and the faster the air is going to move because it's just going to say, I need to get out of here. They don't like to be in a small space, so they're just going to leave. So again, just kind of overview again of pulmonary ventilation. So inhalation, volume increases. The pressure outside the body, meaning atmospheric, is higher than the pressure inside, meaning in the alveoli. So pressure inside is decreased, so air is going to go from high to low, so it goes into the lungs. Exhalation is the opposite. Volume decreases just by those passive muscles relaxing. Pressure outside is less than the pressure inside. So the atmospheric pressure is lower than the pressure inside the lungs. So air is going to move out. So it's all based on changing pressures. No, I've mentioned it a lot, but it can get confusing. So direction of airflow is because of the difference of pressures. So the difference between atmospheric pressure, air all around on the outside, and intrapulmonary pressure, which is the pressure inside the respiratory tract. But we focus on the alveoli because, again, that's where the magic's happening. So that's where gas exchange or external respiration is happening. And so that's what we really care about. How much air is getting to the alveoli? If air is not getting down into the alveoli, well, then external respiration's not occurring. That's not good. So we look at the pressure changes again. So if we have high pressure in the lungs or higher atmosphere or higher pressure in the alveoli, then it's going to move out. If we have lower pressure in the alveoli, then it's going to move, air is going to move in. So some terms associated with respiration, this is going to be the last part of this video. First is called tidal volume. Tidal volume is normal breathing. So it's the amount of air that comes in a normal breath and the amount of air that goes out in a normal breath. So again, inhalation is going to be the intrapulmonary pressure is less than atmospheric. So air is going to move in because you have lower pressure, it moves into the lungs. Exhalation is going to be intrapulmonary pressure is higher than the atmospheric pressure, so it's going to push air out of the lungs. So tidal volume is just normal breathing, just in and out, in and out, in and out. So you look at tidal volume. So this is looking at pressure differences here. So again, pressure is going to get more negative because it's going to be less than atmospheric in inhalation because you want air to go in. And then it's going to get higher or more than atmospheric in exhalation because you want air to go out. So average about 500 mils of air is going to come in and out of the lungs with a tidal volume. And again, that's depends on the person. It's individual. Then you have reserve volumes. So this is going to be how much extra. So how much extra air can you bring in with a deep breath, deep inspiration? So you breathe normally, how much more air can you suck into your lungs? And it's kind of I mean, again, it's individual. So it's how much you can expand your rib cage and your thoracic cage more with those extra muscles. So taking a deep breath in, whatever you can go past your normal breathing. So breathe in, breathe out, and then breathe in, and then breathe in some more. The extra that you're bringing in is your inspiratory reserve volume. So this expiratory reserve volume is the opposite. So it's a deep expiration or exhalation. So inspiration or inhalation, expiration or exhalation. So this is the amount of air that you can get rid of extra past in tidal volume. So you breathe in and breathe out. That's tidal volume. Then breathe out a little extra. Kind of breathe in normally, breathe out normally, and then just really kind of try to expel more air. That's your expiratory reserve volume. So it's just the extra that we can get in or the extra that we can get out past that tidal volume. Then we look at inspiratory capacity. That is adding your tidal volume and your inspiratory reserve volume. So this is how much absolutely you can inhale at one time. So you can only inhale so much. There's only so much you can make the size of your thoracic cavity be large and change the pressure where air is going to come in. So it's normal breath plus that extra that you can take in a deep inspiration. That's the total amount of air that you can bring into your body. Your forced vital capacity includes your expiratory reserve volume. So this inspiratory is just how much you can take in total. Take in total. Forced vital capacity is how much you can take in total and how much you can kind of get out. So the total amount that you can get in and the total amount you can get out. Absolutely. No past that. So it's your tidal volume plus your expiratory reserve volume and your inspiratory reserve volume. So this is the max amount of air you can move. You can't move any air past this. Normal breath, how much you can extra get out and how much extra you can get in. And you're thinking, okay, well, there's got to be where it's just everything is emptied or everything that comes in is emptied out. But there is what we call a residual volume, meaning there's always air in your lungs, no matter what. So you're breathing in and you're breathing out, but air's remaining in the lungs and the alveoli as you're breathing out. Not all of the air in expiration is removed from your lungs. Why? We don't want our alveoli to collapse. We want our alveoli to stay open so that air can easily flow in and out. If after we expired, there's no air in it, then your alveoli are going to collapse on each other, kind of smush down. Well, there's a lot more difficulty in getting air in an alveoli that's smushed down and air out of an alveoli smushed down versus one that has a wide opening. So that's why you maintain at least a little bit of air. It's not tons, but a little bit of air in your lungs. So when you're looking at total lung capacity, this is how much the lungs can kind of move and hold. So how much air is going to be around your lungs and involved with it. So you're going to take your forced vital capacity, the amount of air that you can move in and out of the lungs per cycle, especially if you're doing really deep breath and a really forced exhalation, then you just add your reserve volume. So the air that remains in there is going to be how much total air possible that you could potentially move. Even though you're not moving your residual volume, it's not really a clinical, total lung capacity is not really clinical because it's hard to kind of tell how much air is staying in. But if we add that, that's as much of the lung capacity, how much air can be kind of in the lungs or out of the lungs at one time.